Hello, friends. Today, let's talk about a very invasive and a very controversial topic that is decompressive craniectomy. Now, it's a neurosurgical procedure, and its main goal is to decrease the ICP, intracranial pressure. To be more precise, refractory ICP. Because why refractory? Because suppose intracranial pressure has been increased due to any cause, and you have tried all the measures, medical treatment to decrease that ICP, and but still the ICP remains high, increased. So in that cases, that is the refractory ICP increased. We will go for this last resource to decrease the ICP. That is this surgical procedure, neurosurgical procedure, decompressive craniectomy. So main goal is to decrease the refractory ICP or decrease the refractory intracranial hypertension, which couldn't be decreased due to medical treatments already tried, which we will discuss later. So let's go and start discussing about this topic. Let's start. So, before going and discussing about the decompressive craniectomy itself, let's talk about the Monro-Kellie doctrine or Monro-Kellie hypothesis. Basically, what this Monro-Kellie doctrine says, um, it defines our head, our cranium, as a closed space, closed from all side, which has three components inside. One is your brain, one is your blood, and one is your CSF, cerebrospinal fluid. So you can think about this as a one-room apartment where three friends are staying. One is your blood, one is your brain, and one is your CSF. So already, since it is a one-room apartment and three friends are staying in that closed space, it's already very congested. So suppose a fourth friend comes and visits and starts staying over there for a few days. It will be all okay, but later on, of course, it will create problems. So it won't be a good situation where all four friends would be staying in that one room apartment, because those three friends have already adapted and they are staying over there and somehow is manageable. But one more person coming and staying over there is not a good idea. So same way, uh, in our cranium, it's a closed space. Those three friends, that is your blood, brain, and CSF, they are staying over there, and everything is all okay till now. But suppose, due to any reason, a fourth friend, that is fourth friend, we can think about, either it can be a tumor, either it can be your hematoma, bleeding in the brain, or your ischemia, yeah, infarct. So any of these are your fourth friend, and any of these, suppose they enter and inside that space, closed cranium, so it won't be a good idea. So it will create some problems. So those problems can cause death too. So let's talk about, so basically the fourth friend will cause your increased ICP. So any of the tumor, hematoma, ischemia, or infarct, or cerebral edema, uh, any of these would cause your increased ICP. So this is what Monro-Kellie says, defines as your cranium is a closed space, closed from every side, closed. It is inside bone, yeah, which is a hard structure, which can be expanded. So uh, only three structures, therefore, are left, which can change in volume or change in structure somehow. So those are your blood, brain, and CSF. Because bone will remain where it is; it won't expand. So that's the main idea about Monro-Kellie doctrine. It is like, it's a cranium is a closed space with these three constituents. So if any of one of those constituent, either blood, either the brain, or either the CSF increases, if any one of them increases, the rest two should decrease. Because if one of those is increased, of course, to remain in that space, the two of other two will of course decrease. So here we can see, uh, ICP, intracranial pressure, it won't increase till a certain limit. Here we can see in the on the y-axis, we have the ICP, intracranial pressure, and here we can see in on the x-axis it's the volume. So it can be a volume of your blood, it can be a volume of your brain, it's brain parenchyma itself, or it could be your CSF volume. So suppose here we can see, suppose brain is increasing, brain parenchyma is increasing, or blood is increasing, or the CFS is increasing. The ICP somehow will remain till 10. As we know, the ICP normal value is somewhere from 10 till 20. Yeah, in between the 10 to 20 millimeter of mercury. So till here, suppose any of, if either blood increases or your CSF increases or any brain parenchyma increases due to tumor or something, till this limit, till here, the volume, suppose let's say this is 50 ml, till 50 ml, suppose on the x-axis, the volume increases of that fourth friend. Yeah, if it increases till here, ICP remains till 10, till between 10 to 20. But at a certain point, if that volume of that either blood, either brain, or either CSF increases, then you will see a drastical change in the ICP. There would be a sharp increase in the ICP, so which is very critical and which is very deadly. So few compensatory mechanism works to maintain that ICP till in between 10 to 20, but till a certain level. If that level is exceeded, then the ICP, this compensatory mechanism will fail, and that will cause your sharp increase in your ICP. That would cause focal ischemia, global ischemia, herniation, and ultimately leading to death. So now these compensatory mechanism, what they can be? Compensatory mechanism can be like drainage of CSF. Yeah. Now CSF drainage can be increased. So that can be a compensatory mechanism. So, this is how your compensatory mechanism or decrease cerebral blood flow. All will these cause somehow, depending on which volume, which component has been increased, either it is blood or brain or CSF. But the main compensatory mechanism would be your CSF drainage. Your CSF displacement will be increased to maintain this ICP, because as we know, cerebral perfusion pressure is equal to your mean arterial pressure and minus your ICP. So ICP is the one which is leading, which is causing your cerebral perfusion pressure uh, to be maintained. So suppose if ICP is increased, your CPP, your cerebral perfusion pressure, will decreased, and therefore, if cerebral perfusion pressure, the perfusion of the brain is decreased, that will of course cause ischemia. So ICP is the main parameter, or which controls your cerebral perfusion pressure. CPP, cerebral perfusion pressure, is constitutes of two main thing. One is your mean arterial pressure, and one is your ICP, intracranial pressure. Mean arterial pressure, as we know, it is your systolic blood pressure, and minus your twice of your diastolic pressure, and you're dividing it by 3. There's a formula for for your cerebral perfusion, mean arterial pressure, sorry. So mean arterial pressure, suppose mean arterial pressure is very easy to calculate. It is systolic blood pressure. So let's say, assume someone has a systolic blood pressure of 140, and um, someone and the person has the diastolic blood pressure of 160. Yeah, so 140 minus twice of um, 80. Diastolic blood pressure is suppose 80, so 80 or twice, it will be 160. 160 plus systolic blood pressure, it will be your 300. 300 divided by 3, so your systolic, your mean arterial pressure would be around 100 exactly. So 100 minus, and suppose your diastolic blood your ICP is around 20. So 100 minus 20, it's 80. That is your cerebral perfusion pressure. And 80 is a good value for cerebral perfusion pressure. Usually it should always be above 50 in the last um, lowest, and but it should be somewhere around above your 70. So as already mentioned, your cerebral perfusion pressure is very important, because if cerebral perfusion pressure is decreased, that will cause your ischemia and ultimately infarct and brain death, or due to edema caused, it will cause your further um, herniation and ultimately death. So again, a very important point: your cerebral perfusion pressure, yeah, has two parameters. Yeah, it is controlled by two parameters. One is your mean arterial pressure, that is your MAP, and one is your ICP. So cerebral CPP, cerebral perfusion pressure, is equal to MAP minus ICP. How do you calculate MAP? Mean arterial pressure. Mean arterial pressure formula is very important. It is your systolic blood pressure minus twice of your diastolic blood pressure, and divided by 3, everything. All right. So how to calculate mean arterial pressure, mean MAP? Suppose, assume systolic blood pressure is 120, and your let's say 140, because to make it round. Suppose your systolic blood pressure is 140 and your diastolic blood pressure is 80. So, according to the formula, you have to double the diastolic blood pressure. So, 80 into 2, it will be 160. 160 plus systolic blood pressure, as I already said, 160, 140 was your systolic blood pressure. 140 plus 160 is your 300. Divide that by 3. So, it will come to 100. So, 100 is your MAP, mean arterial pressure. Now, minus it, now subtract 20, that is your ICP, out of that mean arterial pressure. So mean arterial pressure was 100 minus ICP, that is 20. So your intracranial pressure, your cerebral perfusion pressure will be 100 minus 20, it will be 100. So 100 is a good cerebral perfusion pressure. So this is very important according to this doctrine, Monro-Kellie. Let's go to the next slide. Now, indication of decompressive craniectomy. Now, decompressive craniectomy it can be either primary or it can be secondary. Now, primary one is also known as your prophylactic, and secondary is known as your therapeutic. Now, primary is prophylactic. Why? Suppose um, someone comes with a motor vehicle accident and has a acute subdural hematoma or an epidural hematoma. So in that case, you're operating on that patient. While operating, you assume that this patient will have increased ICP later on, because you see brain is swelling, and there is a significant brain edema. So in that case, you already assume that maybe later, after once the operation is done, maybe after a few hours or the next day, or in the after next day, or maybe in the evening, the patient ICP will increase. So in that case, what you did is you went for a craniotomy. You did a craniotomy, but later on you turned the craniotomy to be craniectomy. That I will discuss what's the difference between craniotomy and craniectomy. Now, craniotomy and craniectomy, it can be the procedure to remove the bone, because you're removing the bone is the same thing. Just the only difference between craniotomy and craniectomy is, in craniotomy, you put the bone back, whereas in craniectomy, you remove the bone and maybe put it back, but on a later stage, maybe after a few days, and not at that particular moment you're putting the bone back. So that's the basic difference between a craniotomy and craniectomy. For an example, you are doing a operation on a brain tumor. You operated on it. So since you remove the brain tumor, you know you have removed the bone, you have removed the tumor. Now, as you know, the tumor, the ICP won't be increased. So in that case, you will put the bone back, bone flap. You will put the bone flap back. So in that case, it's a craniotomy. It's not a craniectomy. Craniectomy would be when you remove a part of a bone, skull bone, and you, with the intention of not putting it back, you're not putting it back. So that's a craniectomy. So, all right. So going back to our primary and prophylactic, what's the difference? So in primary and prophylactic is, why it is prophylactic. Just imagine you assume that the ICP would be increased in the coming future. So in that case, what you will do is you won't put the bone back. Yeah, you started for some other thing to operate. You operated for that particular lesion, hematoma. You operated on that patient for that hematoma, but while operating, you you have seen few clinical few signs that brain is expanding. There's a edema, and so in that case, you will convert that craniotomy into craniectomy. And how do you do that? You do it simply by not putting the bone back. So that's why it's a craniectomy. Yeah. So it's a very confusing words, confusing terms for many students. So in first of all, this is a decompressive. Yeah. Already it's a decompressive because you are doing it decompressive, maybe craniotomy you were doing, but in the OR on the operating table, you notice like brain is getting swollen up, and since itself it is getting swollen on the operating theater, in the operating theater while you're operating, so of course it will further uh, increased. Yeah, so in that case you will convert the craniotomy into craniectomy simply by not putting the bone back. And that is one decompressive one decompressive craniectomy, which is prophylactic. Your intention was not to do a craniectomy. Your intention was to do a craniotomy, to operate for, suppose, for tumor, for acute subdural basically not for tumor, but suppose you were operating for acute subdural hematoma. Yeah, you were doing a craniotomy, you were doing a decompressive craniotomy. But as I already mentioned, you saw brain is getting swollen up. So in that case, you converted that decompressive craniotomy into decompressive craniectomy. Yeah, DC is for decompressive craniectomy. So you won't put the bone flap back. So you assume primary prophylactic is for you assume that ICP will increase. Yeah, it at the moment while you were operating, it wasn't it was in a normal values. Yeah, between 10 to 20 millimeter of mercury. But while you were operating it, you notice that ICP will increase. So primary prophylactic decompressive craniectomy is for avoiding the increase in ICP, yeah, in the later stages. Whereas your secondary therapeutic decompressive craniectomy is done when there's already a refractory increase in ICP. Yeah, there's already an increase in ICP. So in that case, you do secondary decompressive craniectomy as a last resource to treat that refractory intracranial hypertension or ICP. So primary is for to avoid the ICP, and secondary is to treat the ICP. All right, and to be mentioned here, we are talking about not the just simple increased ICP. We are talking about refractory ICP, ICP which couldn't be decreased due to any medical measures already taken. All right. Now, as I already mentioned, craniotomy and craniectomy. Craniotomy is done. It's not about the size. It's all about even this much structure, this bone flap you are taking out. It can be even a craniotomy or it can be a craniectomy. The only difference is in craniotomy, you put the bone back as soon as you are finished with the operation. You do the operation, you operate on that patient, and you put the bone flap back there and then. Whereas in craniectomy, you take out the bone flap, but you aren't putting it back at that particular moment. Yeah, it would maybe it will be after 1 week, 5 days, 10 days, after 6 months, depending on the for which the operation has been done and about the how the ICP has been managed. So only difference in the craniotomy and craniectomy terms is, in craniotomy you put the bone back there and then, and whereas in craniectomy at a very later stage you are putting the bone flap back. Now, decompressive craniectomy, basic three types are: it can be frontal, bifrontal, it can be unilateral, that is your hemicraniectomy, and one is your posteriorly, that is your suboccipital or the posterior fossa decompressive craniectomy. Yeah, all these are for the decompressive purposes. Yeah, because decompressive purposes is because as I already mentioned, when compensatory mechanism couldn't function to maintain the ICP, then everything is everything is not functioning well. So you need to decompensate. So how do you decompensate? You remove bone. Yeah, you remove that bone so that your brain has enough space to expand. Yeah, so that's the main role. So we'll discuss one by one each one of them. So it can be bifrontal, hemicraniectomy, posterior fossa. Yeah. So let's talk about the hemicraniectomy. So what happens is, now your this bony area, your bony skull, can be taken out. Either it can be done unilaterally, decompressive craniectomy can be done unilaterally, or it can be done bilaterally. Yeah, that is, it can be frontal, or in the very rare cases, it can be frontotemporal parietal bilateral. So basically, hemicraniectomy, this one is hemicraniectomy. If we are talking about the hemicraniectomy, we are talking about the unilateral decompressive craniectomy, unilateral DC. Yeah. So why this is craniotomy? Why this is craniectomy and not a craniotomy? Because we won't put the bone back. We won't put the bone back here. So that's why it's a craniectomy first of all. And why decompressive? Because we are doing it for the decompressive purpose. Yeah. And why unilateral? Because it will be unilateral. And another name for hemicraniectomy, it could be your fronto, temporo, and parietal bone flap. Yeah. So this is the part of the frontal bone taken out. Here's the part of your temporal bone taken out. And here's the part of your parietal bone taken out. So that's why it's a hemicraniectomy. Yeah. And it could be, so one of your decompressive craniectomy can be your hemicraniectomy. So after doing your skin incision and taking all the temporalis muscle and with the skin flap taken out, reflected anteriorly and inferiorly over here, we reach this bone. Yeah. So after reaching this bone, we make burr holes. So here we can see burr hole, burr hole, burr hole, burr hole. Then with a foot plate of a craniotome, what we will do is, with the help of that instrument, we will do a craniotomy in this fashion. Yeah, like this. All right. So skin incision, of course, skin incision over here for hemicraniectomy would be somewhere here, because here's your ear, here is your tragus, external auditory meatus. So we will remain 1 centimeter less, 1 centimeter less, so to avoid your superficial temporal artery over here. Then our skin incision will go like this up, yeah, over here. Then we will take it back posteriorly like this, and over here, avoiding the astrium and everything, and going in the front. This is, I'm talking about the skin incision. I'm not talking about the bony flap here. Skin incision will be like this, going posteriorly, coming superiorly, yeah, and somewhere lateral to your midline, and coming inside and till your widow's peak over here, yeah, till the midline over here. We will That would be our skin incision, and here is the bony flap. Here's the craniotome, and we will take out this bony area, all of this. Again, here we can see the skin incision for the hemicraniectomy. We can see two skin incision can be done. One is your, like, over here. So we will start from here. Here's inside here in front of the triggers. This distance should be less than 1 centimeter. So to avoid your super STA, superficial temporal artery, we will take like this incision with the scalpel, 15 centimeter blade like this, going back, enclosing, enveloping this upper part of our ear, and going posteriorly like this, and going uh, somehow remaining near the midline and going in front of the here at the widow's peak till here, till your hairline ends. Or another incision, it could be going from your widow's peak, doing a skin incision, going till posteriorly below your inion over there, and taking a T point, taking a again same enclosing covering like this, and this will avoid your facial nerve, frontal branch, yeah, frontal branch of your facial nerve. So avoiding by this with this incision. So this is a T incision, and this is your kind of a question mark. Here we can see, here we have the um, widow's peak over here behind the hairline. Here we start the incision, or you can start over here, covering coming from here, going posteriorly, remaining to your midline, and coming till your widow's peak. So this is all about the skin incision, we can say. So here we can see superficial temporal artery over here. So avoiding it. Here we can see, here we have the zygomatic arch. Here we have the triggers, and 1 centimeter. This distance for this skin incision should be 1 centimeter. So to avoid that artery over here. So, and coming like this. So this skin incision is itself just like a trauma flap, you can say. So same skin incision. And location of burr holes for the, this is for the trauma flap. Here it will be, it's not about the decompressive craniectomy, it's about the trauma flap which is made, and it is for the exploratory burr holes which are done. So for suppose acute epidural hematoma, if a patient has, so your first burr hole would be here, then you go for in the frontal region, then in the parietal region, and last you go in the occipital region if suppose you haven't seen blood coming out in the epidural area. Again, is this is your triggers over here. Distance for the skin, your starting of the incision should be less than 1 centimeter over here. You start the incision going posteriorly, then taking a anterior curve and remaining lateral to the midline, and here somewhere in at the your hairline or the widow's peak you stop incision. So your skin flap was this much, whereas your craniotomy or your bony flap would be shown by this one over here. So with the help of a craniotome, you will make this, you will take out this bony flap and substitute it by your burr holes here, 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 here. So this is how you will do your perform your hemicraniectomy. So as you can see, hemicraniectomy uh, is focusing on three bones. One is your frontal, one is your temporal, and one is your parietal. So that's why it's a frontotemporal-parietal bony flap, unilateral. So hemicraniectomy. Now here we can see this image showing your decompressive craniectomy. We took out this musculo and your skin flap, musculocutaneous flap, taken out, reflected anteriorly and inferiorly. Then we can see the bone over here. Then we make few burr holes with this with the um, craniotome, with the, and with the help of the foot plate, we take out, we connect these burr holes. We are connecting these burr holes, and after connecting this burr hole, we will take out your bone. So this is a decompressive craniectomy. So bone is removed, but the operation doesn't finish here after removing the bone. The main major very important point to remember of the decompressive craniectomy is after removing the bone, dura mater um, is very important to dissect and to remove the dura mater as well. Very, very important, because if you don't remove dura mater, then uh, no use of removing the bone, because dura mater itself will compress your brain, and brain won't be able to expand. Because as I already mentioned, our role for decompressive craniectomy is for the let the brain expand. Yeah. Now, decompressive craniectomy itself will cause some edema. Yeah, it itself will cause edema, but that's why it's a controversial whether it helps or not. But decompressive craniectomy itself, it helps to decrease ICP, uh, and bring it back to less than 20 centimeter, 20 millimeter of mercury. So that's why decompressive craniectomy is very important. But the main point is, after removing the bony flap, it's very important to remove and dissect the dura as well. And after that, important point is, you need to do after the durotomy, yeah, after the craniectomy, durotomy, you need to do duroplasty too. Yeah, so duroplasty is very important. Either you can use your some dural material, yeah, substitute, dural substitute, which can be used, or if you don't have, then it might be duroplasty somehow can be uh, left alone. But dural substitute are basically involved, are very useful. Yeah, after removing the dura, it's useful because somehow it protects your brain. Now let's talk about the bifrontal decompressive craniectomy. Here we can see now the indication of bifrontal, sorry, and for the decompressive, for your hemicraniectomy over here, basically it is done on the non-dominant area, non-dominant side. That is basically basically on the right side. It involve basically we do it on the right side. But suppose a lesion is on the left side, as we can see, the lesion is on the left side. So in that case, done on the left side as well. So it can be done. So that's how that's about the hemicraniectomy. Bifrontal decompressive craniectomy, it is usually done. Suppose there's a diffuse brain swelling, cerebral edema, and it's a diffuse one. So in those cases, for the diffuse brain swelling, when every other measure has been taken, suppose you for medical treatment, like you have given mannitol, hyperosmolar treatment, yeah, like 3% saline, hypertonic saline, you have hyperventilated the patient, you have elevated the head of the patient to 35, 45 degree, 30 to 45 degree, and suppose all of these measures you have already taken, you're hyperventilating the patient, giving these mannitol or hypertonic saline solutions, and still there's a ICP remains increased, that is your refractory ICP, it's not getting decreased. Then in that cases, and you can on the CT scan you can see diffuse brain swelling. So in that case you will do bifrontal decompressive craniectomy. So again, taking out the skin, here's the coronal suture, incision starts over here near the your hairline, and behind the coronal suture over here. So this is for the bifrontal decompressive craniectomy. You remove this part of the bone, and you do the you remove the dura as well, and you do the duroplasty. In this case, for the bifrontal decompressive craniectomy, we must remember we will ligate your superior sagittal suture over here. We will ligate it and dissect it. Yeah. But whereas for the unilateral decompressive craniectomy, frontal craniectomy, bilateral, unilateral frontal craniectomy, what you will do is, suppose you are doing it bilaterally, that this portion of the bone over here will remain over the superior sagittal sinus in the middle, in the midline. Yeah, over here this area of the frontal bone will remain, we will leave it, and it should not be that much broad, because it will cause bleeding and it can injure your superior sagittal sinus is that case. But here we will do, here this one is bifrontal. For unilateral we will same by skin incisions, skin incision would be same, but just the bone would be, we will take from here and this area, and another one this area, this area of the bone will remain. So this is for bifrontal decompressive craniectomy, done for your diffuse cerebral edema most of the time. Again, here we can see the coronal suture over here. we can see over here the superior sagittal sinus going posteriorly, and here is your over here we can see the skin incision, and here we have done the um, bony craniotomy over here. Yeah, we have done the craniotomy, and hence this will be a craniectomy because we will remove and remove this bony skull, bony part, this bony flap. We will remove it. So for the burr holes, we can see, since the superior sagittal sinus is over here, our two burr holes are placed laterally to the superior sagittal sinus at around 3 centimeter bilaterally at the distance, one and behind the coronal suture. Here we can see the coronal suture, and here we can see the superior sagittal sinus. So our burr hole would be behind the coronal suture and lateral to the superior sagittal sinus bilaterally. And here we can see we will go superior to the orbital rim over here, and here it will be overall constitute our frontal bifrontal craniotomy. And as for the hemicraniectomy, as I already mentioned, important thing is this over here, your per hole should be as inferior as it can be, because we have to somehow reach and um, uh, help the middle cranial fossa to be relieved too. Yeah, so that's why the burr hole over here should be as inferior as possible, like we can see over here in the temporal region. So these burr holes should be as low as possible, because somehow to help the brain to um, have enough space of the middle cranial fossa also. Now, posterior fossa decompressive craniectomy would be, suppose there's a infarction in the posterior cerebellum over there. So in that case, we will take out the skin flap, skin removed. Then our here we can see that skin incision. Skin incision, of course, it will be midline over here like this. With the retractors, we will take out the skin on bilaterally on that side and that side. Then for the craniotome, what we'll do is, if we will come till here, we can see the external protuberance, or we can see the inion over here. So inion can be felt, and our incision was from inion to your C1, C2 level. And but for the craniotomy part, the craniectomy part, which this bone will be removed, of the occipital bone would be removed. And along with that, we can see here we have the C1 vertebra. We will do the C1 laminectomy also here. So here we can see the foramen magnum. So here we have the enough space. This bony part would be removed. Would be removed. So for the posterior fossa, the suboccipital craniectomy, uh, important is midline incision. There would be a midline incision, bone removed, along with the C1 laminectomy, and the dura would be incised in the Y shape like this, removing the dura, and a decompressive craniectomy would be done. Whereas for the hemicraniectomy or another craniectomy, which I already mentioned, our dura would be removed in a circular motion. Yeah. And this one is basically performed Y-shaped incision. Here we can see the skin incision from the inion till the C2 level. So a skin incision is done in the midline at the back. Then taking it out laterally, bilaterally, skin incision. Then here we reach the bone. We make a burr hole on either side. Now burr hole should be important. It should avoid your transverse and your sagittal sinus over here. So we must take care of them. And here would be your craniectomy done in this area. Now in this one we can see bone is removed. So a craniectomy, decompressive craniectomy or suboccipital craniectomy has been done. Here is your inion. And C1 laminectomy, as we can see, done. Now looking at few pictures, here we can see here we have the decompressive craniectomy already done. Here we have the CT scan. Now this white structure is your bone. We can see this white structure is not present here. That means the bone has been removed, and through that space we can see the brain coming out. So brain has enough space to come out, and so this is one of the complication of decompressive craniectomy, is that the brain herniates. There can be bleeding over here, yeah, and it can cause ischemia to this area if it's not enough enlarged. So that's why craniectomy, decompressive craniectomy, should be done at least 12 centimeter anterior posteriorly. Yeah, so this is anterior posteriorly, diameter should be 12 centimeter, or the basic one is your 15 centimeter is much more acceptable. So it should be minimum 12 centimeter till 15 centimeter. That is a good decompressive craniectomy done. Along with that, dura mater should be removed, and this is here we can see um, brain coming out from the decompressive craniectomy. Here, here is cranioplasty done maybe after 6 months, 8 months. Basically, if it's a small bony flap, a small bony defect, then we can use a titanium. But if it's a long bony defect like this, either we can put this bone back of this craniectomy. Now, what we can do with the bone, if it was a penetrating trauma, road vehicle accident, road motor accident, and it was this bony flap and the skin that was penetrating, and it was looking not so good, and it was kind of uh, spoiled with soil and everything. So of course we won't use that bone. We will throw that bone. But suppose there was an infarction, so a middle cerebral artery infarction in the this area. So that's basically a sterile. That's not that much contaminated wound or contaminated um, bone. So in that case, we can put the bone back. But suppose for the penetrating trauma, and where there's the bone has been contaminated or the skin has been contaminated due to the penetrating trauma, so in that case we will throw that bone, and on the later stage when we will do this cranioplasty, we will put this bone back. In that case, we will use methyl methacrylate, which is a very good option because um, you can on the spot you can measure all the diameter, anterior posterior diameter, and you can measure it, and you can use that material methometrically to exactly put it back, and hence cranioplasty done. Suppose it was a bony defect, very less, like 2 centimeter, 3 centimeter. In that case, you can use your titanium. But we aren't talking about titanium in this case, and we aren't talking about 2 3 centimeter because we aren't talking about decompressive craniectomy. Decompressive craniectomy should be minimum 12 centimeter, between 12 to 15 centimeter, to be called a good, acceptable decompressive craniectomy. Here we can see decompressive craniectomy done. This is a hemicraniectomy, fronto-temporoparietal craniectomy. Why craniectomy? Because I already mentioned, bone has been removed, and you can see for sure this craniectomy has been done very nicely, in a nice fashion, because its diameter is definitely more than 12 centimeter anterior posterior. This is anterior, this is posterior, so diameter is definitely more than 12 to 12, in between 12 and 15 centimeter. So this is a hemicraniectomy, or we can say frontotemporoparietal craniectomy, decompressive craniectomy. Here's a cranioplasty. Here we can see they've done a cranioplasty. Bone, what basically you can do with this bone. Suppose you took out this bony flap. What basically you can do with this bone is, suppose you can put the bone in the patient's subcutaneous abdomen. Yeah, you make an incision in the patient's abdomen, and in the subcutaneous layer you can put this skull bone, this bony flap of your head cranium, and put in that later. And suppose you need to operate after 6 months, then you operate and take out that bone from the abdomen subcutaneous layer and put this back. But as I already mentioned, suppose there's a penetrating trauma and the it is injured, it is contaminated. So in that case, you won't use that bone back. So you can you will use some bony material like methyl methacrylate to substitute for that bone. Or you can suppose uh, either you can put this bone in the abdomen, or you can put this bone in the antibiotic solution and in a intestine packages which come for, and you can put in the refrigerator and use it for the later purposes. Here we can see, here's the midline shift, here's the MLS midline shift towards the contralateral side, towards the right side over here. This one is your right, this one is your left. Here we can see subdural, acute subdural hematoma, which is compressing on the brain and shifting it to the opposite contralateral side, that is toward the right side. Midline shift. So of course, this is a uh, quite indication of decompressive craniectomy. But what happens is, we have started for the decompressive craniotomy, but while in the operation, we can see significant brain swelling over here. See all this hypodense area, and here's hematoma also formation inside. So of course we can assume that there would be a increased ICP even in the later stage. So we best so best thing to be done over here is, we won't put the bone back. Instead, what we did, we just took the bone and removed it and never kept it back, put it back at that stage, so that we already knew that brain will swell, and therefore we need to give this brain enough space to expand. And therefore we did this decompressive craniectomy for as a prophylactic measure. So that's why this one would be your prophylactic decompressive craniectomy and not a therapeutic decompressive craniectomy. As I already mentioned, therapeutic decompressive craniectomy would be for your diffuse brain swelling after you have done everything else. You have hyperventilated the patient, you have given mannitol, everything. You have all the measures which could be taken, yeah, are not functioning. ICP is again above 40, above 30. Then in that case, you will do therapeutic decompressive craniectomy. But since here we operated for some other thing, that is for acute subdural hematoma, but while operating we assume that this patient will have increased ICP, so hence we did decompressive craniectomy in this case, kind of hemicraniectomy. Here we can see again, this is a hemicraniectomy. We can see here is the musculocutaneous flap taken out, anteriorly and inferiorly. Here are the burr holes we can see. Now these burr holes are done to connect and take out the bone. And in some cases, for acute epidural hematoma, we can easily uh, decompress. But we aren't talking about the acute epidural hematoma at this stage. We will discuss that in another video. So here we can see the image of the patient exactly lying like this. Incision was made in front of the tragus, in front of the ear, taken back posteriorly to the midline, remaining lateral to the midline, and coming and finishing the skin incision at the widow's peak or behind the hairline over here. And then with the help of the craniotome, we will take out this bone out. And here we can see a very good decompressive bony flap over here. Sizes between 12 to 14 centimeter anterior posteriorly. So this is a very acceptable bony flap. And here we can see duratomy done. So again, a perfect next step for decompressive craniectomy. So, and here we can see we have done the duroplasty over here with the dural substitute taken. So attached over here, duroplasty also done, and skin will be sutured over here, but bone won't be put back. So these are the few steps for decompressive craniectomy: bone taken out and dura mater taken out. And so craniectomy and durotomy are the basic main procedure. Duroplasty depends. It should be done, of course. Here we can see again a reconstructed image of a hemicraniectomy done. So here is a well done decompressive craniectomy. And about the burr hole, which I already mentioned, the burr hole in the temporal region over here should be as inferior as possible, because here we have the middle cranial fossa. So to decompress the MCF, middle cranial fossa as well. So these burr holes are very important. And here we can see anterior posterior diameter somewhere between 12 to 15 centimeter, easily appreciated. And decompressive craniectomy done. And here is the dural substitute. It's not a brain, it's a dural substitute. So this is a after reconstruction done after the decompressive craniectomy, hemicraniectomy, or we can say unilateral hemicraniectomy, or we can see frontotemporal parietal craniectomy, hemicraniectomy. Here we can see the bifrontal craniectomy. Here we have the position of the superior sagittal suture. Now this one is not. This one is unilateral. This one is unilateral frontal craniectomy, but done bilaterally. Because in the previous slide, I have talked about bifrontal craniectomy, which was not taking the issue of superior sagittal sinus here. But in this case, if it's done unilaterally on both sides, in this case, this bony part would be remained intact. This part would be remain intact. What we will do is we will take like this bone, like this, and this area, and we can take on that side as well. This part can be left as itself, because and it shouldn't be that much large, because then it can injure your superior sagittal sinus. So this is your unilateral frontal craniectomy done on both sides. Here are the burr holes behind the coronal suture and lateral to your superior sagittal sinus. Now here in this image we can see brain herniating through your this uh, decompressive craniectomy done through this defect. And this is the main aim of your decompressive craniectomy, to let the brain expand, because as according to Monro-Kellie, if this was closed, brain doesn't have nowhere to go. So in that case, taking out this bone, it helps it out, it helps this brain to swell. So of course decompressive craniectomy itself leads to brain edema, but what can be done, we need to do it, because ICP will anyhow come down less than 20. So that's our main goal for decompressive craniectomy. Of course, the comorbidities and everything, will remain. Patient will have disability later on, but at least the patient might survive. So here we can see that's why it's about anterior posterior diameter should be bigger, as large as possible, because here we can see here's the bony flap, here's the bony margins, and here's the decompressive craniectomy. And if it was too small, that it could cause necrosis or ischemia of that part herniating. So that's why if it's large, so somehow it it's maintaining that basic formation, basic structure of the brain herniating through it. It's not compressing the brain that much on the here as well. But overall, the complication of decompressive craniectomy remains bleeding and leading to your hygromas or your hematomas as this at this level, wherever the decompressive craniectomy has been done. Here we can see the suboccipital craniectomy or the posterior fossa craniectomy. Here is we can see ischemia, infarct on the cerebellum, on the right cerebellum, and therefore craniectomy, decompressive craniectomy has been done. Posterior fossa decompressive craniectomy, bone has been removed, and as I already said, the skin incision will start at the inion or at the external uh, protuberance at the occipital bone over there, and skin incision will go till C1 C2 level, C2, and then then bone will be removed along with your C1 laminectomy will be done over here, therefore leading to your uh, expansion of the brain and swelling, because cerebral edema can be caused because of the traumatic brain injury or because of ischemia. infarction, all can lead to your cerebral edema, and hence therefore leading to your increased ICP, and of course leading to herniation. So for the avoidance of this bone has been removed over here. See, in this structure, we can't see the white structure. That is, our bone has been removed. This is post-operative image, CT scan done. That's all. Hope you enjoyed. Hope you understood something. Um, that's all. Thank you. Have a good day. Bye bye.